Nazer Prognostic Index. The Nazer Prognostic Index is an index of the liver functions on point scoring from three liver functions. Number 1, serum bilirubin, number 2, serum aspartate, and number 3, prothrombin time. Each one gets 4 points, and it starts from normal to abnormal 0 to highest 4 points. So briefly here I discuss 4 points. The 0.4 level of the Nazer score is number 1, serum bilirubin is more than 17.5 milligram per 100 ml. But doing this serum bilirubin exclude hemolysis. If there is hemolysis, it gives a wrong figure. Number 2, serum aspartate AST is more than 300 international units per liter, and number 3, prothrombin time is more than 20. So in 0.4 scoring of a Nazer, serum bilirubin more than 17.5 milligram, serum aspartate more than 300 international unit per liter, and prothrombin time is more than 20. Patient management with Nazer score. Number 1, with score 7, patient is managed with trientine and zinc, and these two drugs should be given 1 hour apart. Number 2 is between score 7 and 9, where there is hepatic decompensation, the same medicine, trientine and zinc. Number 3, with the score of more than 9, hepatic transplant. So management with Nazer scoring is up to score 9. It's trientine plus zinc 1 hour apart, and if the score is more than 9, then the treatment is hepatic transplant. Now treatment of the Wilson disease. Number 1, all pre-symptomatic patients should be treated as the disease is 100% penetrant. So all pre-symptomatic patients should be treated. Number 2, anti-copper treatment is lifelong. Number 3, low copper diet and no copper cookware should be used. Number 4, medications, chelating agents, trientine and D-penicillamine. But D-penicillamine is toxic and it worsens neurological disease. It should be given with vitamin B6. So amongst the chelating agent, trientine is preferred over D-penicillin because of its toxicity and neurological worsening. Number 3, zinc. Zinc competes with copper in the GIT for its absorption, so reduces copper absorption. So what's the drug of choice in Wilson disease? Number 1, without hepatic decompensation, the drug of first choice is zinc. Number 2, in mild to moderate hepatic decompensation, trientine plus zinc. And number 3, with severe hepatic decompensation, there occur hepatic encephalopathy and portal hypertension. The treatment is liver transplantation. And number 4, for neurologic and psychiatric disease, tetrathiomolybdate plus zinc. So the drug of choices in different stages of the Wilson disease are: number 1, without hepatic decompensation, treatment of choice is zinc. Number 2, with mild to moderate hepatic decompensation, trientine plus zinc. Number 3, with severe hepatic decompensation, liver transplant. And number 4, neurologic and psychiatric disease, tetrathiomolybdate plus zinc. Why is zinc used as a first choice for Wilson disease treatment? So zinc is used as the first choice in Wilson disease because number 1, it's safe in Wilson disease. Number 2, zinc competes with copper in GIT for its absorption, so decreases the copper absorption. And number 3, zinc induces metallothionein synthesis which sequesters copper. So zinc is safe in Wilson disease, competes with copper and prevents its absorption. And number 3, it induces metallothionein which sequesters copper. Zinc is used for maintenance therapy also, and also for pre-symptomatic patients, pregnancy, pediatric patients, and for non-decompensated hepatic disease or cirrhosis. So these are the uses of zinc in Wilson disease. Now treatment of the neurological disease. The drug of choice for neuropsychiatric disease is tetrathiomolybdate. So why is it used? It has low toxicity, a rapid onset of action, preserves neurological function. Zinc can be given with tetrathiomolybdate, but penicillamine and trientine worsen the neurological conditions. Hepatic transplant improves neurological conditions. Neurologic and psychiatric symptoms improve 6 to 24 months after starting the treatment.